Let's get to the next part of our time together. I'll summarize where we are. So among the things that I think we need to be thinking about as we move into this population-based type of care, I call this my lucky 7 list. So number 1, what about your own employees? Well, at Catholic Health Partners, 35,000 employees, Humana, 51,000, Jefferson, 9,000. This is really, really important challenge that we're going to have. So part 1, what about our own people? Part 2, keep the people who are already healthy, healthy. So this is the work of D. Eddington and others at the University of Michigan. Really important concept. Got to keep the healthy people healthy, too. Number 3, patient-centered medical homes. I get it, you get it. Who will lead these things? That's the core question. That's a board-level governance decision to allocate resources for training. Registries, we hammered that. You're not there yet. You're making progress, but you ain't close on the registry function. Retail clinics, so you don't have too much of this in your market. It's huge in the East, right? So 6, 7 years ago, Take Care, Minute Clinic, we were all fighting them, hoping they would go away. Put some steroid cream on it, it'll be gone in the morning, Now they're our best pals, because if we could triage the really not sick to these visits, great. The pediatricians fought these like crazy. Are you open at 6 a.m.? I love the pediatric offices where the staff goes on lunch break and they put the phone on and the time when most working people can call the office. Is that patient-centric care? You know it's not. And they fought tooth and nail the private practice pediatrician's story for another time. Managed care partners, I already alluded to that. If Humana landed in your market, what would you do? Would you run? Would you partner? Important question. And number 7, my hobby horse, none of this is possible without leadership training. Who are we kidding? You want leaders? Pay for their training. It's really straightforward. We'll come back to that. Okay, so let me turn to the last part of our time together. I hope you enjoy this. Raise your hand if you've done this. Right? Okay. So I'm watching the clock. Fortunately, we have a half hour of question and answer, so I got a little buffer here. So let me go to part 4 as advertised. Where are we going? What's the summary? I'm going to skip this in the interest of time. Okay, so a couple of take-home messages, and then we'll talk about some squirrely stuff for the future, and we'll have plenty of time for questions and answers, too. So every doctor is a leader. The power of the pen puts them in that role. And so board members, here's the couple of key closing questions. What resources are you allocating for the system to give David the wherewithal to build the physician leadership class that you're lusting for in 2014 and you're going to need in 2015, 16, and 17? Now, does every doctor need a master's degree in quality and safety? That'd be awesome. I don't think it's realistic. So I would just urge you, like Iowa, Oxner, Scott and White, Texas Children's, these are the 4 that I'm involved in, who have robust physician leadership training programs internally. And they're building the David Pates of the future right now. That's what I would argue. That's your responsibility. That's a governance decision to allocate the resources. Here's the CEO checklist that you're going to hold David accountable to. You've seen this from the Institute of Medicine. It's not complicated, but it's got all the core components. And we won't take time this morning, but it appears to me that you're tackling almost every one of these. So kudos on that, as we talked about earlier this morning. Okay. So here's the president of your medical staff. Right? So let me leave you with some take-home messages, right? Major themes moving forward. Review. Transparency and accountability. If you're worried about transparency and accountability, you ought to be. Let me let that hang in the air for a moment, right? If report card time in your house was a time of angst rather than a time of celebration, then you've got a problem. You know exactly, every parent knows exactly what I'm talking about. And part 3, no outcome, no income. Now, how do we get there? Summary slide. Okay, not easy. Every one of these is a lifetime's worth of work, pretty much. Number 1, practice based on the best available evidence, 1991 definition of quality. You cannot do population-based care till you lick number 1. Can't be done. You can't get to B till you do A. Number 2, reduce unexplained clinical variation. At St. Luke's, we've studied the best way to treat heart failure, and this is how we do it here. And we're sorry, Dr. Nash, but you need remedial work for the next couple of months to understand the St. Luke's approach. And in another year, when your credentials are going to be reevaluated, we'll make a final decision. At the Everett Clinic in suburban Seattle, every doctor who they hire is on probation by definition for the first 2 years. Do they all survive past year 2? No. So are you prepared to do that? Number 3, reduce slavish adherence to professional autonomy. It's a fancy way of saying, this is how I was trained. I know I'm good. Just ask any faculty member at Jefferson. The truth is, when we see the actual data, that ain't the case. Continuously measure and close the feedback loop. You're going to have presentations on that today and tomorrow. Great. And then finally, engage with patients. Now, we have not explicitly talked about that, so I'm going to use chair prerogative, take 6 extra minutes to talk about number 5, which is, in the population health world, we're going to need to engage with patients. Let me set it up for you. So you saw Leah, Rachel, and Jacob, right? So Jacob lives in Denver. He's going to move to Boise. Got a better job. Awesome. Off the payroll, double awesome. Now he'd like a doctor, because he faced this decision in Denver. He fell on the ice and cracked a rib and, gets on the Skype phone with my wife. Oh, I'm dying, Ma. Great. Now he's got to find a doctor in Denver. Let's just say it's in Boise. How exactly do you do that? Let's remember a couple of things about who we're talking about. We're talking about a 23-year-old guy. There is no known measure of time short enough to measure his attention span. He's your future patient. Right. You think he's going to call a 1-800 number to make an appointment? Forget it. If you're not online, you don't exist. How cool is your Facebook page, your Twitter feed, your blog? If it's not cool, he ain't coming to you. No way. Now, Leah and Rachel, as women, head of household with regard to healthcare decision-making, so they're 26 by 35 married moms. They're the bosses. That's your future target audience. How are you going to engage with them? Let's just remember a few things about Leah and Rachel, right? So they grew up, since they're 10 years old, email, cell phones, the world's knowledge at their fingertips. You really want to have some fun with folks at that age? Here, I got a couple leading questions for you. Ask them to explain the Dewey Decimal System. Or my favorite, discuss with them writing a check for cash. You want to really have a good dinner conversation? Yeah, I'll get into it. So it's all about mobile applications, connectivity, constant conversation. And for Leah Nash, who you saw, if the background color of your website is not pleasing to her, it's over. You think I'm kidding? I am absolutely, deadly serious. I'm so serious that Humana, we're putting billions with a B in exactly how to do this. Because we know that's the future. And if we're going to ever cut costs and practice population-based care, you can't do it without the population engaged with you. Let me show you some stuff, what I mean. So here's Primary Care 2025. I didn't write this. It's a great report from the Institute for the Future. So here's let me just get to this because it's so cool. So here's your digital coach. So this chick's an avatar online. David, you're eating too much fat. Where'd that voice come from? Right? We've watched you last 3 days of caloric intake. What were you thinking? It already exists. So Eric Topol's book, The Disruption of American Medicine, it's all about implementing this right now at the Scripps Clinic. So we didn't make this stuff up. This is incredibly powerful. So I'm not saying tomorrow, boy, St. Luke's, you're going to go and do this, but to engage with patients in the future, these are the kinds of tools you're going to need. Okay, final stuff. So here I am, occupying Wall Street. You get that, right? All right, so let me show you some stuff from Humana. I'm going to blow you away, then we'll quit. All right, so I got special permission to show you this. Three slides right out of a board briefing book. So 5% of Humana's 13 million customers, 5% drive 41% of our total medical expenditure. Right? Now, if I did this for St. Luke's, it would probably be pretty comparable. Okay, so what's the plan? What's the plan? What are we going to do with these 5%? The answer is everything humanly possible to keep them out of Jefferson and St. Luke's. That's the business model. Let me give you something very aggravating to think about. At this moment, February 21, 2014, which stakeholder has total economic alignment with prevention and wellness? One more time, which stakeholder in the system today is totally economically aligned with prevention and wellness? Hint, it ain't St. Luke's. It's Humana. And her sister companies, profit and not for profit, right? So the Cigna, Aetna, WellPoint, and Uniteds of the world, that's the top 5, they all got the same problem. So what are we doing with those 5%? I'll tell you. We're going to drive a Humana truck to pick them up and bring them to the Humana Center in Florida, and we'll bring all the specialists to see them. We'll coordinate their care. We'll let them play ping pong. We'll feed them lunch. We'll sell them dog food, whatever it is. But we're going to coordinate every aspect. We're going to go and visit their house. See that shag rug in the bathroom? Out of there. Here's your pill box, and here's the nurse who's going to visit you once every 6 weeks, like my mother, in Senior Bridge, in Boynton Beach. Every 6 weeks, the nurse shows up and checks her pill box, takes her blood pressure, phones my brother and me. Awesome. Do you do that? Does Jefferson do that? That's what it might take. Now, imagine doing that with Leah and Rachel. Well, you're not going to fill their pill box, but you better give them some cool stuff like a coupon for the gym, or a free yoga class after work, or a St. Luke's branded yoga mat, or a nutrition consult that comes with their membership, or a free cooking class, or an online game that they could play that they find cool and engaging. Everything I just told you is already being done. So, whoa, patient engagement, this is complicated. So let me show you. Again, we don't have time, but we're moving to what's going to be called the retailization of health insurance. It's going to be like buying soap. And they're going to advertise just like, Procter & Gamble. More on that in the question and answer period. This is just to blow you away, the number of companies out there that Humana is tracking. I mean, in each of the sectors, clinical, administrative, and my favorite sector, look at this. I mean, these are just some of the consumer companies that we have our eyes on. iTriage is an Aetna company where an Aetna beneficiary could call up and say, I don't feel good, what should I do? Oh, well, if our goal is to keep you out of the hospital, we're going to be all over that. We want to know everything about you, and we'll help you as part of your membership fee. So you get the idea where I'm going with this. Okay, let's wrap up. A lot of interesting stuff coming down the road. Here's a scholarly journal called Games for Health. I'm sure you're all regular readers. There's a whole field of amazingly smart people learning how to do patient engagement. So I don't want you to leave with patient engagement as the top thing, but a huge topic we haven't really talked about till now. Okay, I'm going to skip all this. This is another cool thing. Okay, last 3 slides and we'll quit and go to questions. So let me come back to where we were. We did 4 things, right? Part 1, how do we get in this jam? Medical error is the 4th leading cause of death in the United States in the 21st century. Shame on us. Everywhere but Jefferson and St. Luke's anyway. Part 2, population health, been around 35 years. 15% of a population's well-being is based on what you and I do at the bedside. The other 85% is that messy social stuff. Part 3, health reform. Forget the exchanges, this is a sideshow. Health reform is all about using economic incentives to drive a change in clinical behavior in the hopes of improving outcome. Big experiment. We're a couple of years into it. And in part 4, whoa, no outcome, no income, patient engagement. So let me leave you with a couple of final thoughts. So here's a little bit about our School of Population Health. And again, I sure hope you'll join me in Philadelphia. You'll take all the handouts. My goal is to not carry anything back on the airplane tomorrow. But will one school fix what's broke? You know, certainly not. But 4 schools might, 10 schools definitely, 30 schools with all this new stuff, well, now we got a fighting chance. Sending doctors, nurses, pharmacists, board members for ongoing education in all aspects of this, well, that's great. You don't need a master's degree. So come to our 1-day program, come to our 5-day program. I'll bring it to you. You get the idea. There's lots of opportunities to engage with further learning, not just with us, but with lots of very credible places working on these issues as we're standing here. Now, I'm not going to read this out loud because it's a little ribald, but it is my favorite president, and much better to be inside the tent. That's what today and tomorrow is all about, right? Much better to be inside that tent. When I show this at a Catholic Healthcare Partners meeting, boy, did I hear from the sisters. Oh, boy. I kind of slipped past them, but okay. So let me leave you with my last slide, which is really my own personal message. So here's John Cotter, of course, one of the best brains in the business of leadership training at Harvard Business School, 30 books on leadership. So the institutionalization of leadership training is the key attribute of good leadership. Translation, what you're doing today and tomorrow, right? Leadership training. The #1 job of leaders today is to do what? Train the leaders of tomorrow. That's a big deal of what you're doing, right? So let me close by saying once again, I am so thrilled to be a part of today and your program tomorrow. Looking forward to the question and answers. I'm going to be here the whole afternoon, so if you have private questions, I'm happy to engage with you. And God bless you. You're doing God's work. Thank you very much, ladies and gentlemen.
Really well done. Thanks.